चलो ठीक है, बात करते हो बाद में उसकी। जी सर, लिंक 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 ग्रुप
डॉक्टर ग्रोवर को आप
नहीं ग्रुप आई मीन एकेडमी ग्रुप रूम लेंगे जी, जूम पे जाओ, कोई ज्वाइन कर लेगा। यूट्यूब नहीं बस ज्वाइन करना, यूट्यूब नहीं नहीं भेज दे, यूट्यूब लिंक भेज देना। इसको तो मैं इसको जूम नहीं बनता, आवाज नहीं है बस एक यूट्यूब नहीं ना ठीक है। स्टार्ट है लॉगिन कर दो ग्रुप में। So I request everyone to take your seats. So I think Dr. Ashok Grover is not here, and Dr. Swati is also having some fever issue, so she may not join. So I take this opportunity to start this session. Dr. Junos. So today we are lined with two interesting cases. An interesting case of acute aortic sensorium and followed by fever with rash. So first of all, interesting case acute aortic sensorium. To chair session we have Dr. Tiwari, Dr. H.B. Singh. So with the permission of chair, can we start?
Today, we are going to have a very interesting case of acute altered sensorium. Previously, it was guided by Dr. Ashok, but now in his place, Dr. Chaudhary will be there to guide Dr.
Case is being seen by me and as well. So normally the patient has acute aortic sensorium and we have hypoglycemia or encephalopathy. So, but sometimes the unknown cause of encephalopathy or aortic sensorium is there. So it's a very interesting case, and I think Sohan will tell us, and we have a discussion after we finish it up. Sohan, you carry on, and we can have a discussion later on. Yes, please. Diagnosis is done. We'll discuss that session. Right.
Good afternoon to all consultants. Good afternoon, everyone. I am Dr. Sohan Biswas, third-year resident in the Department of Internal Medicine, Max Specialty. Today, I am going to present a very interesting case of acute altered sensorium. So, 45-year-old male with a known history of recurrent glioma with seizures. A 45-year-old male with a known history of recurrent glioma with seizures and hypertension was admitted on the 18th of February 2025 with complaints of high-grade fever, cough with expectoration, and multiple episodes of vomiting for the last 10 days. Outside labs revealed thrombocytopenia of around 90,000. LFT and KFT was within normal limits. Now, at the time of admission, the patient was alert, oriented, following commands, vitals were stable. Respiratory examination revealed the presence of bilateral Krebs. So, we admitted the patient as a case of LRTI. Now, on the admission, we sent all the routine labs and investigation. Patient was on antihypertensive and chronic anti-epileptic therapy, which included levetiracetam 1 gram BD, sodium valproate 1 gram BD, and clobazam 5 gram OD. The patient was started on initial symptomatic management along with empirical antibiotics. On 20th of February, a sudden deterioration in the patient's level of was noted. The patient became drowsy, aroused,
if you know the RT, patient is taken over to ICU. What are the beds available? Anywhere. So there's RT team there in every ICU, in every hospital, hospital. There's intensivist, the physician on call, everywhere. And they take the response. It is not a cold flu. Cold flu team is different. This is the RT team, rapid response team, and the patient is not serious, but yes, the patient needs vegetation. Sometimes in a small center where the ICU bed is not available, all full, and what do you do? So in hospital, it was the best ready so that in case any emergency happens in the ward, they just shift it to that group. Anywhere in the ICU. Surgical ICU, respiratory ICU, medical ICU, so whatever is available. So this is the response, RT response team.
Now, the differential diagnosis at that time we considered was an acute CNS infection, meningitis or encephalitis, sepsis-related encephalopathy. The patient was already in LRTI. Could be a case of metabolic encephalopathy, drug toxicity, or any cerebrovascular accident, along with remote possibility of non-convulsive status epilepticus. The next day, labs were as follows.
Your voice.
The next day, labs were as follows. The creatinine was 1.1. The sodium, potassium, calcium, CBC was present at the time of admission. Now, this platelet count low, we did ask the patient about it. Now, the patient was a case of recurrent glioma. So, the last patient received chemotherapy in 2022 with temozolomide. So, and post the chemotherapy, the patient started having a platelet count in the range of 80 to 90,000. So, the other lab findings were a deranged INR of 1.6, a serum valproate level of 95, which was within the therapeutic range. The urine culture showed mixed flora, which was suggestive of contamination. We repeated the urine culture, which was sterile. The blood culture was sterile. So at this stage, and then we did a MRI vein with contrast because of the encephalopathy. We showed no infarct, no hemorrhage, and no mass effect due to the glioma. Given the patient's altered sensorium and already a known case of epilepsy, a possibility of non-NCSE was considered and an urgent EEG was done, but it's no epileptic form discharges, but revealed generalized background slowing consistent with metabolic or toxic encephalopathy. Now, serum ammonia level was sent at that day and was significantly elevated at 123. Despite no change in other parameters, the patient's mental condition continued to deteriorate. Anti-hyperammonemic measures were started, but the patient continued to decline. And on 24th of February, we repeated the ammonia level, which further increased to 181, despite continuing all anti-hyperammonemic measures.
So this is very astonishing that patient has hyperammonia. So there are a lot of called hyperammonia.
ammonia. Most common cause is definitely conjunctival disease, where we see patients going into incapacity. So, but patient can give any signs, symptoms of conjunctival disease. Some immediate ultrasound normal no liver involvement. Another liver test was not good disease, except for thrombocytopenia that you said it probably due to so, with from 123 ammonia to but I think normal is at 85, I think. Normal ammonia levels.
Yes.
This is hyperalbumic encephalopathy basically.
So considering that the patient INR was deranged of 1.6, the platelets count was also low, and the patient had a raised ammonia level. We did thought of that the patient could be having an underlying CLD. So we did an abdominal ultrasound, which was normal. We also did a titration CT, but there was no evidence of any CLD, so hepatic encephalopathy was ruled out. Now, with CNS, hepatic, renal, and infectious causes being ruled out, we then finally turned to that it could be a case of drug-induced encephalopathy. And since the patient was already on valproate, so we considered that this could be a case of valproate-induced hyperammonemic encephalopathy.
The valproate was 98, it's high normal. So it's a normal way, but it's high normal. But we excluded everything and organ capacity, MRI was done. Put on any including or liver disease or other metabolic factors. So we just narrow down to take valproate-induced hyperammonemia, and definitely we need to start the hyperammonemia measures and use them.
So the valproate dose was accordingly tapered. The patient was initially on 1 gram BD. We immediately tapered it down to 500 mg BD, and for the next 2 days, and ultimately we stopped and we switched to an alternative anti-epileptic drug.
Already drugs for this medicine now already taken, and along with this started
Lacosamide.
Lacosamide. 250 milligram. I think twice daily we started.
As part, all the anti-hyperammonemic measures like rifaximin, lactulose was already ongoing. After considering that it could be a case of valproate-induced hyperammonemia, we started L-ornithine L-aspartate infusion, which was 30 gram over 24 hours, and along with IV levofanatin. We give a loading dose of 6 gram, and then we continued at 1 gram thrice daily. On 26, the ammonia level, and it went further up to 220 status through 48 hours after stopping the valproate, and the repeat ammonia level on the 28th of February came to be within the normal levels, and the neurological status returned back to the pre-admission levels. The patient was finally discharged after 10 days of admission in a fully conscious and oriented state. The patient did follow up in the OPD after 1 month with normal ammonia levels and no seizure episode.
Every patient which have aortic sensory, we should rule out the drug toxicity. Right? The patient is already on levocetine for almost 3 years. You just give it. After the infection, the pneumonia that comes up, right? It triggers the valproate toxicity. Patient gets to hypertonic. We manage the patient with this carotene, that's part of it. There are several outcomes. The patient is running better and still has the seizure activity for almost 3 months now.
So the current case points out that despite normal hepatic function, a normal level of serum valproate level, valproate can still trigger hyperammonemia. Now the question arises that why would valproate cause a raised ammonia in this patient when the patient is already on long-term valproate therapy? It was not like we started and it was an acute presentation. The patient was already on valproate for the last 3 years. So from the literature, what we could find is that valproate decreases the carnitine levels, and carnitine transport the fatty acids into the mitochondria for the beta oxidation. Valproate itself is metabolized through the beta oxidation. So if the carnitine is depleted, so the valproate will not be metabolized properly, leading to the toxic accumulation. Second, it triggers catabolic state. So it will lead to more protein breakdown. So there will be more substrate available for ammonia, and the liver is at the cellular level is already damaged. So we cannot find it out through a liver function test or an ultrasound or a CT. But at the cellular level, the mitochondria in the liver is damaged. And the third could be that there could be that the patient is suffering from a urea cycle disorder. And only when the patient is in acute stress, this kind of presentation becomes evident. So for that, we need to do a genetic analysis. And the last is that the patient is having a transient renal function, which is not the case. Now, a very brief review of literature on valproate-induced hyperammonemia. Now, valproate is an anti-epileptic drug, and a known but under-recognized adverse effect is hyperammonemia, leading to encephalopathy in the presence of normal liver function level and normal therapeutic levels of valproate. Now, the mechanism of action is that valproate inhibits the CPS1 level. So, we all know that this is the urea cycle. So, the ammonia is cycled to the urea cycle, and the first enzyme is the CPS1. Now, valproate directly inhibits the CPS1. So, leading to a disruption in the urea cycle, ultimately leading to a raised ammonia. Now, the symptoms could be from fever. Now, carnitine, as I told, that carnitine is vital for transporting the long chain fatty acid into the mitochondria for beta oxidation. Now, valproate inhibits this carnitine synthesis. So, it leads to more mitochondrial dysfunction and reduced ATP production. And ATP is essential for the urea cycle, particularly for the CPS1. Without sufficient ATP, ammonia can't be detoxified, leading to hyperammonemia. And as I said, that valproate metabolism itself requires beta oxidation. When the mitochondria is damaged, the beta oxidation will not be happening, shifting to a omega oxidation, and this will produce toxic metabolite like valproyl coenzyme A or propionyl coenzyme A, which further damages the mitochondria. So it turns into a vicious cycle. Now, the clinical features could be from fatigue, nausea, vomiting, ataxia to confusion, lethargy, disorientation, and even in the comatose state. The investigations would reveal a raised serum ammonia level. We will show a generalized flowing, and the plasma carnitine level, if checked, would be low. So the main point is that the patient will be having a normal serum valproate level, and the patient will be having a normal liver function levels. The imaging will be unremarkable, except that the patient will be having a raised ammonia. Now, the management, the cornerstone management is we have to stop valproate. That is the main line of action. Along with, we have to start our routine anti-hyperammonemic measures to, we'll start lactulose to at least 2 to 3 motions per day, and specific to valproate-induced hyperammonemia, we can start a levocarnitine. So the loading dose by 50 mg you can give. We gave the patient 6 gram loading and 1 gram TDS. And along with that, we can give L-ornithine, L-aspartate infusion. So it will be given at around 20 to 30 grams over 24 hours. So we give the patient 20 gram over 24 hours and switching the patient to an alternate anti-epileptic. The most patients will recover fully if treated on. We have to consider a valproate-induced hyperammonemia in patients on long-term valproate presenting with altered mental status with normal hepatic functions.
Basically, ultrasensorium on anti-epileptics, we would actually do a medical levels, right, to see a patient. Yes. We are not without a doubt of disease. But probably the patient infection also be okay. We got this alcoholic dose and pneumonia, infection and CT short and this factor also.
Yes, sir. Yes.
So right now the antibiotics only around we saw the patient got water sensorium. This only began of this the Twitter is a normal, what is normal?
So a very brief about that. Apart from valproate, we also need to be considering what other drug also causes hyperammonemia. So another anti-epileptic drug, topiramate, causes that the kidney increases the ammonia production to buffer the acid. So that is ammonia. Acetazolamide, which is a common drug, is metabolic alkalosis and alkaline. And when the urine is alkaline, the ammonium ion is converted to ammonia, and ammonia is readily absorbed. So both metabolic acidosis and alkalosis can lead to raised ammonia levels. And the last is that steroids, by virtue of being a increasing the protein catabolism, increases the amino acid turnover.
Ammonia level correlate with the consciousness level of ammonia. Like in this case, initially it was more than that patient was unconscious, and then ammonia level raised to right. So it is ongoing, right? The ammonia is ongoing. But from 123 to 221, a patient is from cortical sensorium gone into sort of comatose state. After 2 to 3 days, patient was not responsive. So if you continue this valproate, patient what is the treatment of choice? You have to reduce the dose of valproate. So the problem is anti-epileptic. You can't reduce it, no, certainly. This community treatment to bridge the gap so that if this valproate level goes down, the patient the level also comes down, and so what will happen. So patient is having the only treatment, because these are the hypothesis what why happened was a mitochondrial dysfunction. Valproate was a mitochondrial dysfunction with different methods. Treatment is otherwise only you have to reduce the dose of valproate. But in this treatment, you can't reduce suddenly because if you stop the drug, the breakthrough is there and the patient very difficult to manage. We started these add-ons as the other epileptic, and we started the reducing dose of valproate. And when we started to reduce the dose of valproate, the ammonia level also came down. This is the way that we have to do it. So it can be reached for a long yes, yes. When the patient comes yes. Yeah, the valproate is very controlled drug actually, but it is a very good drug also, and the patient well controlled with valproate for last 3 years. So the story is that the patient admitted yesterday was I just got a phone call from my resident that this patient admitted yesterday with seizure, breakthrough seizure. Yesterday, sir, the patient being admitted at from this under neurologic care. So when we switched all the patient to other drugs, so I think the patient was very well managed with valproate. So now the patient again admitted with seizure, and you have to again modify the drug. But we can't start valproate in this patient. We have to do the alternate treatment for that. So presently the patient is on, I think, clobazam and lacosamide and levetiracetam. This side of it, this side of it, is it duration? Yeah. Actually, the patient was settled. The trigger, what triggers it actually? Infection actually. Infection triggers the valproate. Yes, increase ammonia production of decrease and increase mitochondrial dysfunction. So probably the trigger, the infection, the stress, that triggered the patient, and they because the patient is stable and patient can be switched over to valproate until patient not having the weakness stability. So we can put the patient valproate again after some time when the patient is headlong. But patient What is the minimum dose of valproate? So you discuss with the neurologist. The minimum dose is 5 grams once a day. 5 grams once a day. For prophylaxis, because we have been using with this migraine prophylaxis also as well. The migraine prophylaxis is the dose 50 to 5 milligrams once a day. But for seizure disorder, accurate is 1.5 to 2 grams. But the we also welcome Dr. Anita Sehgal for the after a very long time, ma'am. Dr. Sehgal was a very good teacher of our association, and it is on the time when DDP is being formed. But for some reason, we could not have the Sehgal here. Thank you very much, and we hope that you will come regularly to this forum. So I think with this, if you have any questions, then we can start the second. Thank you so much for a very nice. Thank you, Dr. We can take on the second case. I think Nakshi Jan is there. Nakshi, and what do you? You can start the session.
Good afternoon, everyone, and it's a pleasure that we are here to discuss this case. It's really an interesting case, so I want your feedback. So we have Dr. Meghna Arora, who is second year to present.
Good afternoon, everyone. I'm Dr. Meghna Arora, and I'll be presenting a curious case of fever. So, the patient details. The patient is ABC, a 22-year-old female hailing from Delhi, Hindu by religion, and a college student by occupation. She presented with the chief complaints of fever since 1 month, joint pain since 1 month, yellowish discoloration of skin and mucous membrane since 4 to 5 days, rash since 3 days, and vomiting since 3 days. So the patient was apparently normal 1.5 months back when she developed a flu-like illness, where she had fever, joint pains, coryza, lasting 5 days, following which her coryza subsided, but she continued to have large joint pains, which was bilateral knees and ankles. For this, she consulted in the OPD as a case of and was diagnosed as a case of QLE post-viral ulcers and was started on etheric oxide for 7 days. When she had no improvement, HCQS was added and then sulfasalazine were added subsequently. Since the last 1 week, which is up, so there's a lag period of around a month, the patient developed high-grade fever, which was continuous with no diurnal variation, associated with chills but no rigors, relieving with medication for a few years. And she also developed vomiting since the last 3 days, 4 to 5 episodes per day, containing food particles. It was not projectile and non-blood or bile stain. And she also had an erythematous rash present all over the body, maximally on the arms and the face, associated with severe itching. She also complained of constipation and passing clay-colored stools and generalized swelling of the body. She had no history of any cough, weight loss, headache, or any travel history or any pain in the small joints. So past history, there was no similar complaints in the past, no past history of any atopy, no history of comorbidities, no contact with any TB patients. And she had no similar illnesses in the family. On personal history, she was a vegetarian by diet, appetite was reduced, bowel and bladder movements were normal and regular. Sleep was disturbed because of the itching, and she had no habits. So on examination, she was a 22-year-old female patient who was poorly built and nourished, who was conscious, anxious, alert, and well-oriented to time, place, and person. Vitally, her pulse was 98 beats per minute in the left radial artery, regular in rhythm, normal in volume, character, no radiofemoral delay, no vessel wall thickening, or peripheral pulses were normal. When she arrived in the ER, her BP was 90 by 60 millimeters of mercury, but it corrected with 110/70 with fluids. respiratory rate was 20 cycles per minute, abdominal thoracic, and her oxygen saturation was normal. She had some facial puffiness, and then she had some erythematous rash on her arms and face, and icterus was present in the sclera. It was visible. There was no pallor, clubbing cyanosis, or palpable lymphadenopathy. So this was the rash. So it was a erythematous rash, and it was not raised above the skin. And this was her facial swelling, and there was some rash here, which is not very visible in the photo. So on systemic examination, the respiratory system was normal, bilateral normal vesicular breath sounds with no added sounds. CVS was normal, her abdomen was soft, non-tender with no organomegaly. And on CNS, a higher mental focal neurological deficits. So before she presented to the hospital, some investigations were done a couple of days back. So this is a case of last year. So in this, the LFT was done on
Your patient was seen in the OPD in the clinic. This patient had come to me with a history of pains, basically. She had joint pains in all the major joints of the body, and she had all joints of hand which were minimally involved. Basically, knee swelling, ankle swelling, history of morning stiffness, backache, etc. Patient had been having this swelling for 15-20 days prior to coming to me in the OPD. Patient was she was studying in Mumbai and she was a resident of Noida, and she had come for the joint swelling. She gave the history that before coming to me 15-20 days prior to this, she did had a flu-like illness, but that had disappeared. So before I saw her, the joint pains were around 3 weeks in duration. For which at Mumbai, she was taking some painkiller and some COX-2 inhibitors, and she was not getting relief. Swelling was there, and she was not able to go to the college. So her mom got her to Noida. So when I saw her, it was an inflammatory arthritis. The joints were swollen red and inflamed. There was restriction of movement, and there was morning stiffness. In preliminary examination, CRP was very high. It was around 40 or 50. And the CBC and rest of the liver function test, kidney function test were all normal. The basic arthritis panel was negative. RA factor, CCP, ANA, chikungunya serology was all normal. The fever wasn't there. The X-ray chest ultrasound was all normal. So I started her on COX-2 inhibitor and on some HCQS. But her pain did not get relieved and she was not able to go to the college. And the pain continued. So she was started on steroid, HCQS, and sulfasalazine was added. And she did have relief in her arthritis, and the swelling and inflammation reduced. Then a few days later, she developed these problems and she came to the hospital. This picture is when she came to the hospital. So can we go back on the previous slide? So this is after at around 2 weeks or 10 days of starting her on HCQS, sulfasalazine, and on small dose of steroid. Can we go back on the initial presentation? Yeah. So she came, like initially she had a febrile illness. She came to the clinic. She was started on these things. And she was from Mumbai. She came back to her hometown. And I started her on HCQS, steroid, and sulfasalazine. She was not febrile when she had been in Noida. But then she, after 1 week of treatment or 10 days of treatment, she developed fever. And let's go further. She developed fever and vomiting and erythematous rash. Go further. And no other history. Go ahead. Go ahead. And this was the examination. That patient felt sick and I asked her to come to the emergency. And in the emergency, she had facial puffiness, erythematous rash. Go ahead. And this was the rash. And some rash around the face, around the lips. Go ahead. Right. Rash, 1 week, 7 days. 1 week, 7 days after starting the drugs. And rash was erythematous and yeah,
flu-like illness, and then she developed acute joint pains involving the small joints and the larger joints with infusion. Very, very
dose of steroid, and then she developed fever